Thanks very much. It's a real pleasure to be here. I'll start with disclosures. I don't think there's anything particularly relevant to this meeting. I hope when all of you think of Australia, you think of cute and cuddly animals and people. But I have learnt a lot at this conference, and one of the things I learnt yesterday was that it's appropriate to show clips of movies. And so, whilst you're thinking about how cute and cuddly Australia is,
Outback Australia. Vast. Rugged.
When I was a boy, I was sent way out west to stay with my grandpa.
Come on.
Are there any crocodiles?
Not many.
They can eat you.
Yes.
And the worst snake is a death adder.
Yes.
What happens if you get bitten?
You die.
so what you should take from that is Australians are pretty straightforward and don't tend to embellish things, but also that not everything in Australia is cute and cuddly. So there are these kind of animals as well. But my favourite is the snakes. This is the list of the top 10 most poisonous snakes in the world, and half of them are Australian. But you'll see that in other... Can you hear me? Okay, so just to point out that Australians don't embellish things. In other countries they use names for really bad snakes like black mamba and rattlesnake, but we just go fierce snake and death adder. Okay, so Syringomyelia is not quite that dangerous, but just to point out, sort of the pointer has disappeared. Hello, so you got the pointer? No? Okay. The laser pointer. Yeah, this slide was just to remind everyone about the structure of the spinal cord in cross-section to show. There we go. This is the normal spinal cord, and that's the normal central canal. This is a post-mortem example of a syrinx that involves an enlarged central canal, and this is actually an experimental animal but showing a syrinx outside the central canal, called extracanalicular Syringomyelia. And we discussed this a bit yesterday, but the clinical features used to be thought to be related to damage to the central part of the cord, but at least for canalicular Syringomyelia, we now understand that it's related to dissection or rupture of that central canal syrinx into the dorsal horn, much more than any damage to the central part of the cord. So that for this patient, that enormous syrinx is actually clinically asymptomatic. It's only when it ruptures through like that into the dorsal horn that the person becomes symptomatic. That doesn't have to be large, so that very small rupture like that, or a syrinx that starts outside the central canal like that, or a very bad syrinx like this one, are all symptomatic, but all because they damage the spinal cord tissue, rather than the whole syrinx replacing the cord tissue. We know that Syringomyelia is related to other causes. I agree with Andy that it must always be related to some other cause, and we can generally think about the associated causes in these categories. We know, obviously, that Chiari malformation is a very common cause. Craniocervical junction arachnoiditis, I really think, ought to be considered separately from Chiari malformation. Often the appearances may be similar in terms of the arrangement of the cerebellum, but this is a different condition in my view. We found recently that for most of these cases, the syrinx actually does communicate with the fourth ventricle through the central canal. Spinal cord injury is another well-known association with syrinx. So here's a patient paraplegic from that spinal cord injury, but then at risk of becoming quadriplegic a year or so later because of development of a large syrinx. Spinal arachnoiditis. So I separate craniocervical junction arachnoiditis and spinal arachnoiditis into separate categories. I think they're different conditions. This is an example of a patient who was examined many years ago with an oil-based contrast medium myodil myelography. It's got very extensive arachnoiditis, but presents symptomatic from this very extensive syrinx involving the thoracic, spinal and cervical spinal cord. Spinal cord tumours, so particularly intramedullary tumours, and this is meant to demonstrate ependymoma. This is an example of ependymoma, obviously are associated with Syringomyelia without necessarily any abnormality in the subarachnoid space. Spinal dysraphism, and not just tethered cord from a tight phylum, but in this case a person who had at birth a lipomyelomeningocele that was repaired surgically but has a tethered cord related to that, now has this very extensive syrinx that is what is causing her symptoms rather than the original tethered cord. Then there are cases where there is uncertainty about the underlying condition. So whether that's Chiari malformation or whether it's related to the spinal canal stenosis, the underlying cause here may not be evident on the MR. I have to say that we have moved away from myelography in terms of trying to identify arachnoid pathology and gone more to cardiac-gated, heavily weighted T2 scans. And I hope that demonstrates here that what this shows is that there is an arachnoid band here that wasn't evident on, this is the same case, not evident on the standard T2 scans. Would be difficult to demonstrate on myelography, I think, but that confirmed that that was the region of abnormality and helped us with our surgical decision making to operate at the posterior fossa rather than in the cervical spine. And then there are those where, despite all of our attempts, we're unable to find an associated cause, so syrinx like this. You may tell me this is a glioependymal cyst now, but I still think that's a syrinx. Another similar one where there's no evident underlying cause. We have, I just want to show a few examples of the cardiac-gated, heavily T2 weighted scans to show how useful they are in understanding arachnoid pathology. On the standard T2 scan, that cyst, which actually turned out to be a neuroenteric cyst, was not evident, or not easily evident. It helps us to understand how dynamic Syringomyelia is. So this is a syrinx going right up into the brainstem, but I think it's very easy to appreciate on this dynamic scan how much force is being impacted into that part of the cord. I think one could appreciate how coughing and sneezing could just tip the balance here and cause dissection of that syrinx into cord tissue and create a neurological deficit. And this is another example where the dynamic scan revealed the underlying arachnoid pathology. Again, I hope that demonstrates there's an arachnoid band here. I think most of us would have a clue that there's going to be some pathology at that region because of the sudden change in the caliber or size of the syrinx cavity, but this demonstrated that band quite nicely, and that made a big difference in our practice. So we don't use myelography now, we use these scans. We know that if you treat the underlying condition, in most cases the syrinx will go away. So in Chiari malformation, if you do a posterior fossa decompression like this, the syrinx collapses. And for me, I'm not so fussed about the syrinx going away completely. I just want the syrinx to collapse so that I know that it's not tense anymore, so the person's not at risk of the syrinx dissecting into the surrounding cord tissue. I don't mind if it doesn't go away. This is an example of craniocervical junction arachnoiditis, and I just show this video to give an example of the fourth ventricle outflow obstruction. We showed on intraoperative ultrasound that there was a connection from the syrinx, that syrinx into the fourth ventricle through the central canal, and there was arachnoiditis obstructing the foramen marshalli, and so we put shunts in from the fourth ventricle to the spinal subarachnoid space in those cases. I think this is a different condition to Chiari malformation. Spinal cord tumours, if you take the tumour out, so you open up the spinal cord like this, take out the big tumour, the syrinx will collapse. But there are those cases, patients where the appropriate treatment is not so clear. So for patients who've had posterior fossa decompression for Chiari malformation and the syrinx either doesn't go away or recurs, or particularly for patients with arachnoiditis, particularly with extensive arachnoiditis related to previous trauma, infection or hemorrhage, it's difficult to know how to treat those patients, as well as those patients with idiopathic or where we really can't identify the underlying cause. And dysraphism like this, you could argue that the underlying cause is the persistent tethering of the cord here, but this person still has neurological function in that part of the cord, and detethering that would be extremely difficult. So it's hard to know what the right thing to do is for those patients. And as I said, the idiopathic syrinx like this, I don't think there's any obvious treatment. So the options are, particularly for patients with previous Chiari malformation surgery, redoing the posterior fossa decompression, or if there is concern that this may in fact be Chiari 0 as the underlying condition, then a posterior fossa decompression could be considered. Widening the subarachnoid space at that level with a duroplasty is a possibility, or doing some form of shunt is the other possibility. And then doing a shunt has various flavours, so you could do a ventriculoperitoneal shunt, particularly if it's a clearly communicating syrinx with associated hydrocephalus, or a subarachnoid to peritoneal shunt, the thecoperitoneal shunt we heard about yesterday, or various forms of direct syrinx shunting going to the peritoneal or pleural cavities or into the spinal subarachnoid space. So what I'm going to talk about today is our experience with syrinx to subarachnoid space in the management of this group of patients where the management would otherwise be difficult. I think the theoretical advantage is that it's relatively simple in the sense that you're not going to some other body cavity. The shunt tube is generally very short, and for patients with a large syrinx, it's relatively straightforward to get into the cavity. The theoretical disadvantages are that if we believe the piston theory, or that there is a problem in the subarachnoid space pressure that encourages CSF inflow, then as Andy said yesterday, then surely a shunt would actually allow fluid to come in more than get out. There are concerns, particularly in the literature, about infection, blockage or cord damage at the time of surgery. There are quite a few series in the literature, the largest I think being this one from 2001, but this was from a series where they were treating patients with Chiari malformation as the primary underlying condition, and they were treating those patients with a large syrinx with a syrinx to subarachnoid shunt primarily. And I think most people now would treat those patients with posterior fossa decompression, so I think that's a different category to what we're talking about. This is a review from a couple of years ago looking at various forms of shunting. I've highlighted the ones that had patients with syringo-subarachnoid shunting. And again, a lot of the patients treated here, particularly in the earlier series, are with Chiari malformation or hindbrain herniation as the underlying condition. And so there aren't very many patients reported here for other conditions. And if we look at the outcomes from those series, they're not particularly good. So if you look at the clinical recurrence at follow-up, that ranges up to about 50% in terms of recurrence of the syrinx. I'm not sure why that review didn't include Rick's series from 1998, but that paper also reported a recurrence rate of about 50%. So I think there's a school of thought that shunting is not appropriate, has fallen out of favour, perhaps not so much in dogs. It's been used to treat Syringomyelia in dogs. So in summary there, the role of syrinx to subarachnoid shunting remains unclear perhaps, but our hypothesis is that syrinx to subarachnoid shunts can be safe and effective in appropriately selected cases, and so to check on that we analysed our experience. So from my series of Syringomyelia patients from 2000 to 2016 with 155 operations, these are all the patients with Syringomyelia broken down with the associated underlying disease, most of which are Chiari malformation patients. So we've taken those patients with for shunting, those patients with neurological deficit or neurological symptoms, and then either no underlying cause or where it was considered that treating the underlying cause was too difficult. This is the age, so pretty much equal male and female. This is the age breakdown by decade, so a few children, a few elderly patients. And this is, in blue, the total series, and in red, the syrinx to subarachnoid shunts. There are a couple of patients with Chiari malformation. I'll show you some of those. They were ones where they were not my patients originally, that had the post-operative decompression done elsewhere, but had recurrence or persistence of the syrinx. So just in terms of the technique, I tend to do it at the place where there's the maximum syrinx size and cross-sectional diameter. I use a midline myelotomy unless it very particularly presents at the DRES. And I'm uncomfortable if the distance or the thickness of cord tissue to go through is more than about 2 millimetres. And I use the smallest shunt that I can lay my hands on, which is either a Spätzle or a James lumbar-peritoneal shunt. I just cut off the tip. The outside diameter of those is 1.1 for the Spätzle, 1.3 for the James shunt. I don't mind whether the shunt goes rostral or caudal in the subarachnoid space, but one thing is it has to go into normal subarachnoid space. I position it so that there are holes in the shunt inside and outside of the cord, and I secure it to surrounding arachnoid or the dura. And I very rarely do an associated duroplasty. This is just a video that Andy gave you a teaser of yesterday to show you that sometimes when we open into a syrinx, the fluid inside it can be under quite considerable pressure. So all of this fluid coming out is coming out of a syrinx cavity. But this is just to show you the technique that I use for syrinx to subarachnoid shunt. So it's a midline durotomy, keeping the arachnoid intact for a separate opening. And then I, to retract the dura, open the arachnoid separately. And I'm very careful with the arachnoid. So you'll see that I'll tack the arachnoid up to the dural edge with clips, so that when we close later on, the closure includes the arachnoid, so that the arachnoid remains attached to the dura rather than falling in as a separate layer. And often, usually, the cord will look completely normal on the surface, and so I'm just checking down the side here to make sure the ventral and dorsal subarachnoid space communicates. What I need to do here is find exactly in the midline, which we can find with where the penetrating vessels are. It's underneath this midline vein, so I'm just going to dissect that off by dissecting the arachnoid around the vein, so I can get to the midline to a section where I can make a midline incision in the cord that's long enough to fit that 1.1 or 1.3 millimetre tubing. So by going exactly in the midline, we're theoretically separating the fibres of the dorsal columns and not creating any neurological deficit. In this case, is about 1 or 1.5 millimetres depth to the syrinx cavity. It always seems a long way when you're going through the cord tissue. But here I'm just entering into the syrinx cavity now. And then once I've entered into the syrinx cavity, I can put the catheter in. So that's the section of catheter is about 2 to 3 centimetres long. And that's not a tremor. I'm actually deliberately wriggling it in so that I can get it into the syrinx cavity. And then once it's into the cavity, I can change direction and it slides into the syrinx cavity. And then I just stitch it to the surrounding, if there's arachnoiditis, stitch to the arachnoid or to the surrounding dura. So just some examples. This is a patient who had previously had a posterior fossa decompression, had recurrent syrinx, and then syrinx resolved with a syrinx to subarachnoid shunt. This is a patient where we did demonstrate an arachnoid web, but I do tend to put in a shunt if there's a large syrinx, even though we like to think that we've dealt with the underlying pathology. This is the patient with the lipomyelomyelin and with a simple syrinx to subarachnoid shunt done here, the whole syrinx collapses. This is a post-traumatic syrinx treated with a syrinx to subarachnoid shunt just at the level of trauma, or I think just above the level of trauma. So where the shunt goes into the normal subarachnoid space above. This is one of the idiopathic cases, so we've operated here, checked with intraoperative ultrasound, no arachnoid pathology, nothing evident at the time of surgery, and a syrinx to subarachnoid shunt has been very effective in creating collapse of the syrinx. Another idiopathic case. This is an interesting case in the sense that this patient has 2 syrinx cavities, one in the cervical cord, one in the thoracic cord, and I predicted to this patient that if we put in a shunt into the thoracic syrinx that both cavities would collapse, and that's exactly what happened. So in terms of follow-up, our average follow-up is almost 3 years. In clinical outcome, from the 41 patients, 31 have improved, 8 stable and 2 worse, although they were only temporarily worse, and I'll come to that. In terms of imaging outcomes, 37 had reduction in size of the syrinx cavity. 4 remained stable, and they're generally patients with a post-traumatic syrinx where the arachnoid adhesions remained intact, and we're still optimistic that the shunt reduced the pressure in the syrinx, but no imaging change. We do a short form 12 analysis on every patient with every visit, and that comes down to a physical and mental score. We're not doing this operation trying to improve neurology, we're doing it to prevent worsening of neurology, so we're not expecting a change in SF12, but at least we're demonstrating that we're not getting any worsening after surgery. There are a few complications associated with surgery. One patient had a myocardial infarct, not fatal, post-operatively. 2 temporary CSF leaks, 1 pseudomeningeal requiring surgical correction. 3 of the patients out of 41 reported sensory change in the lower limbs post-operatively, and all of those resolved. 2 patients reported increased pain, and this is what I was talking about yesterday, where when the syrinx collapses, there can be an increase in the activity in the dorsal horns that manifests as increased pain. I think that's the mechanism for these 2 patients, rather than being directly related to any trauma from the shunt. There have been no permanent deficits. I've had to reoperate on 3 patients, and I'll go through each of those. This is a patient with osteogenesis imperfecta who had a spontaneous spinal subarachnoid hemorrhage, and then a year later presented with this syrinx. He had neurological symptoms in his lower limbs, and I suggested at that point that surgery was appropriate. He didn't want to proceed with surgery at that stage. Came back 6 months later with worsening of the syrinx or edema and more definite syrinx cavity. I thought that the arachnoiditis related to the hemorrhage was really focally here, and that led to my operation being at this level to divide the arachnoiditis and put in a shunt. But what happened was, despite getting better clinically initially, he came back a month later worse, and what I worked out was that I had not gone down far enough with the initial laminectomy, so there was still a bit of arachnoiditis below that level, and so I had the shunt going into subarachnoid space just above the level of persisting arachnoiditis. And I think in this particular case, the shunt was allowing CSF to get into the syrinx cavity and expand the syrinx cavity below the level of arachnoiditis. And so to deal with that, I just extended the laminectomy further down, left the shunt as it was, but put a bigger shunt catheter from the subarachnoid space above to the subarachnoid space below to try and keep preservation of the subarachnoid space, and that led to collapse of the syrinx cavity. The other 2 patients had recurrence of the syrinx a year or so after surgery, and at reoperation found that the shunt catheter had come out, and that's led me to be more robust with my securing technique when I suture it in. This is another patient where at reoperation there was the syrinx catheter had just come out. It was still sitting there, and I just had to put it back in and then secure it more robustly. That's a Kaplan-Meier graph showing that the time to revision is in the first couple of years, and we've had no late needs for revision or recurrence of syrinx. So in conclusion, from that series, I'd suggest that syrinx to subarachnoid shunts are safe and effective in selected patients, and in those cases, remains a reasonable treatment. And I think it provides some interesting information about the underlying pathophysiology of Syringomyelia, but that's another talk altogether. So I hope when you think about Australia, you think more about the cuddly creatures than the dangerous ones. Thank you for your attention.
Are there any questions?
Every time I go to place a in it, I get a little nervous by the distortion of the dorsal column by even this tiny little tube, and frequently I'll leave it out because I'm concerned about what I'm doing physically to the nervous tissue. You never have problems with paresthesias after surgery or balance disturbances that the patient complain about?
Nothing. So there were those 3 patients, I think, who had some temporary sensory, because of course I warned them about that preoperatively, so they're looking for it, and I've had only 3 that report it, and it's been temporary for days only, so, and no permanent deficit.
Okay, I'm going to put tubes in now.
But I mean, it's important not to use big tubes. Yeah.
Can I ask, follow-up? So do you follow your patients up with regular imaging? Do you wait for them to get progressive symptoms?
So my approach is a follow-up MRI at 3 months, and then every year until, like, if we get to 5 years and it stays completely the same, I'd suggest we do it every couple of years, or only if they get new symptoms.
Okay. Any other questions? No. Oh, yes.
In your patients that had this procedure, do they mostly have decrease in their, dysesthesias and things like that? Have they mostly found improvement?
It's hard to measure that, isn't it? And so when we do the SF12 as a measure, and there's not really any change, I really emphasise to patients that the goal of surgery is to prevent worsening, and I think we've been effective at doing that. Having said that, my impression is that a lot of patients will report some improvement, but it's, I do counsel them that's not expected. The one thing I would emphasise is that if treating a syrinx for worsening spasms is not, in my experience, very effective.
Another kind of strange question. I had that same surgery, and in the report that the doctor gave me, when they put in the catheter, there was a really, the material was like a dark greenish, nasty looking material that came out, but yours looked nice and clear. Is it common to see that dark green kind of really dark?
I don't think I've ever seen anything green. I've seen the yellowish, perhaps, but that would generally be in association with a tumour.
Oh.
Yeah, but it doesn't sound like yours was that. So I've certainly not seen yellowish fluid in other circumstances.
Okay, thank you.
On patients that have multiple syringes, do you put shunts on all the different syringes, or you select which ones,
So the one case I showed where there were 2 syrinx cavities, we shunted only the larger one, and they both collapsed. And in the series of 41, there are 2 patients exactly like that. I've had other patients where it's more extensive arachnoiditis, and it's really the same syrinx cavity, and they can be complicated in that you putting the catheter in will generally usually collapses the whole syrinx cavity, but in a couple of patients there's a persisting part that may be somewhat separate. But does that answer your question? Usually it's just one.
Yes, I was just wondering if you put the shunt, like you say, in the largest one, is it going to cause the other ones to shrink? So I guess you say.
And they both collapse.
I've got one quick question from over here. Could you just explain to the audience what a dynamic scan is, please, Marcus?
Right. So most of the MRIs that you've seen in the conference so far are just still pictures. The dynamic scans that I showed, where they've taken usually about 25 frames over a cardiac cycle. And the way that they do that is they attach an ECG, EKG monitor onto the patient, repeatedly scan the patient, and then align the scans to the particular phase of the cardiac cycle, and then average them together. So there are 25 frames across a cardiac cycle, and it's played as a movie. Does that make sense? No. Well, similar in the sense, so I didn't show any of the phase contrast or other types of flow studies, but I guess it's a different topic. But what we showed here is the T2, heavily T2 weighted, which according to the brand is either Fiesta or a balanced fast field echo. and that shows the anatomy, whereas the flow studies don't tend to show the anatomy. They keep the structure still and they show the velocity of fluid flow. It's been the standard fluid flow. So we use both, but it's the cardiac gated T2 weighted that are really good scans at showing the arachnoid pathology.
I guess I have a question about how the syrinx can be, how it disappears, you know, going from bottom up or top down. I mean, yesterday there was a huge syrinx, you know, there was the problem at the posterior fossa and there was a decompression, and then every 2 weeks they had follow-up scans and they watched it collapse kind of, you know, from a rostral, caudal fashion. And then in your example, you have like these skip lesions, and you mentioned that the larger one was inferior and probably it's safer to go more inferior, and so you went there and you predicted that the one on top. So I guess my question is, if you would have done the one on top, I mean, would have it accomplished the same thing and kind of drain out the inferior one?
Yeah, so that was a kind of extreme example because the separation between the two cavities was quite large. But in general, I think it's important to recognise that there is no watertight barrier in the whole system. On the one side, there's the blood-brain or blood-spinal cord barrier. So the endothelial cells lining the blood vessels, and on the outside there are tight junctions between the arachnoid cells lining the dura. Between those two layers there are no tight junctions. It is all one fluid cavity. And the only reason that there are separate spaces is the dynamic nature of the fluid flow. So in Syringomyelia there's fluid flowing into the cord. It's constant and it's rapid, and it's getting out, obviously, at the same rate, unless the syrinx is getting bigger. So in all of these cases, there is some mechanism that is either increasing the amount of fluid that's coming in or decreasing the amount that's coming out. So what we're doing with our treatment is restoring that balance. And in the case of the shunt, what we're doing is giving an extra avenue for fluid to go out so that that balance can come back. And then the fluid's still coming in, presumably, by whatever the mechanism is, but now it's getting out, and so the syrinx collapses. But to answer your question, so if you've got two cavities or even septated cavities, it doesn't matter. It's all one fluid space. And so as long as the fluid's getting out, that fluid in the other space can still be in continuity with the one that you're shunting. Does that make sense? Okay. I think that was one where we didn't know what the underlying cause was. I think that's a canalicular syrinx, even though she was symptomatic. And so I'm assuming that there are some adhesions in the ependymal cells, as we've heard about quite a few times in the meeting. The ependymal cells in the central canal become adherent in humans, not in other species, but in humans that happens. And so between those syrinx cavities, presumably the ependymal cells are adherent and not able to expand.
Hi, I had actually two questions. The first, when you stated in the beginning, did you say clinically syrinx is not symptomatic unless it's protruding from the actual spinal cord?
Not quite like that.
Okay, I was a little confused.
What I was trying to say is that you could have a very large syrinx and you won't get a focal neurological deficit because if it's an expansion of the central canal, all the fibres that are going up and down the spinal cord just get stretched around it. It's only if the fluid cavity breaks through that ependymal lining and tears apart the neural connections that the person will become symptomatic or develop deficits.
Okay, the reason why I asked that question is because mine hasn't protruded, but I do have a lot of symptoms.
But I bet if you looked at very detailed axial sections, you will find somewhere where it has ruptured through. Or there are some cases like the post-traumatic or the arachnoiditis cases, it starts outside the central canal. So a priori, it's going to be causing damage to the cord tissue. If it's a Chiari associated one, starts in the central canal. If there are neurological symptoms, it will have ruptured through somewhere.
Okay. And my second question is, before you shunt, do you look for tethered cord?
Yes. So we, yes, and I have in the past sectioned the phylum in the hope that it would resolve idiopathic syrinx cavities, and I've been disappointed. So I look for it, and of course, if there's definitely, if the conus is at a lower level than normal, that would be the first approach if there's nothing else. But I do all that, and I've been disappointed with the effectiveness of section the phylum, not in terms of resolving those symptoms, but in terms of getting the syrinx cavity to collapse. So, I mean, it's a whole separate topic, and I think it's on tomorrow. And I'm all definitely looking for it, but I'm just saying it's not been effective in my experience.
Thank you. Oh, one last question.
I feel like I've been the most controversial speaker in the whole meeting.
Over 40 years ago, I was diagnosed, and it was quite a bit before at least Albany, New York had very good imaging, certainly. And they put a shunt about T4, and the surgeon at the time said that it collapsed very quickly, and he was thrilled. Now, I had a myelogram at the same time, and I vaguely recollect the two residents who were doing it saying, "Oh, she's got Chiari," which I didn't know what it was. I didn't care. I was getting better. I developed more symptoms later. I had the Chiari treated back in '98, got somewhat better and certainly stabilized after that. I've since had a car accident and a couple other things happen. Symptoms are increasing. I'll grant that I'm a lot older. And the neurosurgeon now is saying there's so much scar tissue that he's afraid to try to do anything. Now, exactly where that all is, I suppose, is all up and down my spinal cord. But in terms of, relieving the syrinx again, I don't know if that could even be feasible. And maybe that's not a question for this, but I asked it anyway.
Yeah.
Thank you.
The extensive arachnoiditis is a problem, but if you can, those dynamic scans are very useful, not perfect, but useful in terms of identifying where a normal subarachnoid space is to target the destination for the shunt.
Okay, thank you very much. Thank you, everybody, for the questions as well. Thank you, Professor Stoodley.